And now I'm happy to officially welcome you on our webinar entitled Additive Manufacturing, Conscious Design and Regulatory Aspects for Implantable Devices. And this webinar is organized by MDPI, a pioneer in scholarly open access publishing. MDPI has supported academic communities since 1996. Based in Basel, Switzerland, MDPI has the mission to foster open scientific exchange in all forms across all disciplines. Today's webinar is the part of the MDPI's Journal Designs webinar series. Designs is a peer-reviewed open access journal which provides a unifying research framework for a wide range of engineering designs of disciplines and industrial applications, including mechanical engineering, electrical engineering, automation, civil engineering, mechatronics, aerospace engineering, bioengineering, energy engineering, industrial engineering, and manufacturing systems. On this slide, you can see the program of today's webinar, and we will have 4 speakers today, and there will be Q&A session after every presentation. Please, dear participants, please pay attention that Q&A session is limited by 5 minutes to every speaker. Of course, if you forget to ask, don't have time to ask strictly after the presentation, you have the possibility to ask your question in the end, like before the closing of the webinar. But to make this Q&A session organized more better organized and to make it more structured, we would like to ask you to write your questions in the special Q&A box. As you can see on the slide, the same you can see in the bottom of your screen. Please choose this Q&A box and type your question there. And please remember to add the name of the person to whom you're addressing your question. And if you are interested in submitting your research to the special issue that is linked to this webinar, please visit the website that you can see the link to the website on the slide. The guest editors of this special issue is Dr. Giulia Pascaletti and Dr. Arianna Rossi. And Dr. Giulia Pascaletti is our chair today. And I'm glad to give the floor to Dr. Pascaletti and to start this webinar.
Yes, thank you, Ksenia. Thank you so much for your introduction and welcome to everyone to this webinar that is about, as already Ksenia said, the additive manufacturing and in particular the conscious design and regulatory aspects for implantable devices. I think that today we are going to see a very interesting discussion about this topic because, as you know, in recent years, the additive manufacturing has become a very, it's one of the most used techniques also in the medical field, and in particular when patient-specific devices are designed. And this must be put together with the regulations that are associated with the medical devices. And so nowadays it's no more possible to think to design a medical device, a patient-specific medical device, without thinking about regulations, and so without thinking about the patients where the device will be implanted. So I think that today we are going to hear 4 very interesting presentations about this topic. And so I think that we can start our webinar officially, and we can start with our first presenter, that is Dr. Paul Egan. Dr. Egan is a tenure track assistant professor at the Department of Mechanical Engineering at Texas Tech University, and he's also the head of the Medicine, Mechanics, and Manufacturing Design Lab. Professor Dr. Egan is an expert about the integration of the engineering, design, and techniques with system modelings, optimization, and experimentation on different biomedical systems, and also about the use of computational tools and additive manufacturing in this field. Today, he is going to present, he's going to talk us about the engineering design research innovations for medical design customization. So please, Dr. Egan, when you are ready, you can start.
Yeah, so I think this should be showing my PowerPoint. Let me know if I need to adjust. Thank you for the introduction. So I'm Dr. Paul Egan from Texas Tech University. And so my presentation for today, I'm going to focus a bit more on the topic for the customizable biomedical implants. And so we do a lot of computational design and personalization and 3D printing in my lab. And so first, I'm going to give a short overview of the lab and then really focus in on a few case studies with the biomedical implants for bone tissue engineering. So a little bit about me. So I did my PhD at Carnegie Mellon. I studied engineering design with mechanobiology and user studies and computational design. Then I went to ETH Zurich for a postdoc, and this is where 3D printing was just starting to gain more traction with research and industry. And so I focused there on 3D printing and tissue engineering, particularly for bone. And then I started my lab here at Texas Tech, where we focus on medicine mechanics and manufacturing. And just a little overview about the importance of additive manufacturing in medicine. There's a lot of application areas that can benefit from the customization. So tissue scaffolds is where we're going to be focusing on today. But you can also imagine, so dental implants are replacing molding. Wearable prosthetics can be 3D printing that are customated on a per person basis. We also have safety equipment that was distributed, and made locally on site for emergencies such as COVID. Surgical planning, where you're able to image someone's body through X-ray and then print it so that surgeons have an easier time to recognize it and reason through the surgeries before, and then things like drug delivery through enabling better transfer of drugs through skin. And so in my lab, we focus on the intersection between the medicine, mechanics, and manufacturing, where the medicine really drives the innovation and the design problems we're trying to solve. And then mechanically, we're trying to understand with finite element analysis and testing how it works. Manufacturing is how we build the solution, and then it all comes together with design. And so this is a specific process where we would be proposing a lattice design, and then we have a computational approach to simulate it, automate and search the design space, and then print the solution. And then we can mechanically test the solution. We can use it in the actual medical case and evaluate it. And then we go back through and iterate and improve the design. So although this is one specific process, most elements of design personalization are going to have these in some kind of organization and iteration to improve over time. So the printing capabilities we do FDM printing, which is the most basic printing that you're probably familiar with, which is just the layer by layer printing with the nozzle. And so you can get things like TPU and ABS, and PLA is a biocompatible material. The resin printing is what we're going to focus mostly on today to create high resolution lattices. And so where the resin printing comes into play is you can create these structures that have smaller pores. That's good for biological growth in the body, whereas FDM doesn't quite have that resolution. But the trade-off here is it's harder to get biocompatible materials that are safe for implantation. But you can resin print PLA, and we use methacrylic acid, which is similar. And then powder printing is a way to create mechanisms as well. And so that's been used in implants a lot for metal powder printing. For things, you can create 3D printed titanium and stainless steel for implantation in the body. Some of the other things we do in the lab, we work on prosthetics and food printing. Some of the recent designs publications we've done is a review on additive manufacturing, which has some medical and implant examples in there. And then also we had with our resin printing designing these hierarchical lattices. And so I'll start with our first case study we're going to look at, which is 3D printing implants that are anisotropic, which is tuned for physiological loading. So what we mean specifically by anisotropy is that the mechanical properties are different in one direction compared to the other direction. So if you can imagine in your body how bone is forming in the spine, you have a lot of loading longitudinally, but transverse, you don't have as much loading. And so same with the legs, you get reinforced bone based on the loading conditions it's applied to. And so we want to mimic that with 3D printing. And so our main application is going to be focused on bone fusion. And so here you have a tissue scaffold implant that replaces the intravertebral disc, which is in between two vertebrae. And from those vertebrae, you're going to fuse it into a solid vertebrae over time. And that's because sometimes those intravertebral discs degenerate and you need to partially or fully remove them. And so the common strategy is to do the fusion. And what we're trying to do with the implants is create something that's optimal biomechanically. So for mechanics, that it survives the load and matches the stiffness of bone. And then biologically, that it has these small pores and surface area so tissue gets on the scaffold, but then grows over time so that you can generate bone. And our approach for this is going to be hierarchical. So we have the anisotropic unit cell, which we're going to longitudinally stretch it or squash it. And so that's going to change the direction, the magnitude of the elastic modulus. Then we're going to arrange those unit cells into a hierarchical scaffold. And so that scaffold has a big central pore that's going to allow nutrients to get through and also vascularization or blood vessels to form. And then we can, implement it and test it in the bone fusion case study. And so our design, we have the basic cubic design, that's symmetric, the stretched one, which because we're extending it in this direction, we expect a higher elastic modulus in this direction because those diagonal cross beams are more aligned with the loading direction, and then squashed would do the opposite. But what you're getting here is you're increasing the longitudinal elastic modulus in one direction and then increasing how much the biological growth can occur in the other direction because you have these larger pores. And so we'll try this at a 50% porosity and 70% porosity, which is similar to what bone porosity is. And the main trade-off with porosity is the more porous it is, means you have more space for tissue to grow, but you have less material, so it's going to be less mechanically strong. So what we want to do is get something that's as mechanically strong as possible, but still supports tissue growth. And so we use, this is Envision 1 digital light projection printing. So stereolithography, but you do a whole plane of light at once. And so we're able to create these lattices that have 500 to 800 micron beam diameters. We can print with a biocompatible methacrylic acid polymer. And so that allows us to start testing for these cases that's relevant for implants in the body. And our preliminary results, so we did different aspect ratios of the unit cells and formed them into lattices that were roughly the same size. And you see here with the effective elastic modulus that EX in the transverse direction goes down as you increase that unit cell height. But in the longitudinal direction that's aligned with the loading, you get an increase in that effective elastic modulus. And so that increase in the elastic modulus is coming at a steeper rate than the decrease in the transverse modulus, which is a good sign because that's showing you're overall more mechanically efficient for the amount of weight and material that you're putting in the body. In some of our mechanical testing results, we have a couple of videos here. So this is with the stretched unit cells. What you're going to see is these tend to fail and deform in buckling. So there's a limit to how long you can make those beams before it's going to fail very easily in buckling. And so you can see on the response, it has a high elastic modulus before its first breakage point. Whereas if you tried the opposite strategy with squashing the unit cells, you get a more consistent elastic modulus, so stress-strain response over time, but it's weaker overall. And that's because you have more smaller cells in parallel, in series there. And so our results, we created these hierarchical scaffolds. You can see the 500 micron beam diameter versions here. We tried it with no internal pore and then a large internal pore. And so what you're seeing here in the top right is when you try and print a lattice in DLP and resin printing, you can get this overfusion where the pores just kind of close off because there's too much material there. And so adding that hierarchical pore in the center, it allows you to avoid that over curing, so you get more of the beam diameter that you'd like in the system, but also it's good biologically because you get that large central area for that biological nutrient transport as well. And then to finish off this study, we mapped them to the stiffness. So we created the lattices of all different porosities and beam diameters that we could configure with the different hierarchical pore size. And we found a general trend that no matter what the design change you did, generally, as you increase the porosity, you're going to decrease the stiffness, but you can tune this based on your exact patient needs. So how big the implant needs to be, how heavy that person is, their activity level, to get the stiffness that they would want for that application, but also keeping that good biological growth as well. And so now that we have these physically validated, so we can bring in the computational design to navigate these trade-offs and try and get some optimal solution. And so how we do this is we create a computational model of the scaffold in the computer. And so you can see here in the center, this is a voxelized model where each voxel represents either the structure of the scaffold, the tissue, or the interface between the tissue and the fluids of the body. And so that interface is going to grow based on a curvature model, because when you fabricate these and test them in vitro, so growing cells on them outside the body, you see this curvature-based growth that's very predictive. And so we can use that to create a model. And these are half unit cells so that you can view the inside. You can see a cubic unit cell follows this type of growth pattern, whereas if you introduce more beams, you can get a faster growth because you have that diagonal that's connecting across the center of the scaffold. So you have more surfaces and smaller pores for the tissue to go through. And so you can start looking at these trade-offs of how can I change the topology of this system to maximize the curvature and the cellular growth while also having those good mechanical properties. And so we used our anisotropic model. And so I'll show a video here of if we use small pores of symmetric unit cells, we can get fast growth, but there's not a lot of overall growth because you have more material. If we increase the size of that to allow more tissues to grow, you eventually get a point of curvature where the tissue isn't going to grow anymore because it doesn't have enough curvature to drive that growth. Whereas this anisotropic one that's on the far right, it has slower growth, but more growth overall that's sustained. So that's a benefit for the system to ensure the healing is going to occur. And then, so because we're looking at these biomechanically, we also modeled the elastic response of them. So we created this in Python and Abacus, where we were able to create a design space of different lattices quickly, and then evaluate them in FEA, and then get the elastic modulus. So that combined with the tissue growth algorithm allows us to look at all the designs and compare trade-offs. And so you can see here, the maximum stress from these symmetric unit cells is higher than the ones that are stretched. And so that's what allows those ones to be more mechanically efficient longitudinally. So we created this design space. And in this design space, every single one of these dots represents a unique design. And so these all represent the same designs across these 4 charts, but they're mapped to different, on the top 2 biological attributes, and on the bottom 2 mechanical attributes. So the longitudinal and the transverse elastic modulus, and then the growth density of the tissue and the growth rate of the tissue. And so when you look at these heat maps, you can see those red areas are in different spots over those charts. And you have some reference lines for the 50% and 70% porosity that matches bone well. And so from here, you're going to need to make some decisions among the trade-offs to get what you want for your system. And so to simplify this design space, we put a constraint that we're only going to consider elastic moduli of 200 to 400 megapascals. And then we created the squash, the cubic, and the stretch designs, and we were able to map them from tissue growth rate to growth density and show that in comparison to the symmetrical cubic designs, the squash and the stretch allow you to extend beyond the extremes of the design space and have more options to personalize for the user depending on if you need faster recovery, better mechanical efficiency, or a higher overall bone growth as well. And so this last part that I'm going to talk about is integrated design, where we do multi-objective optimization and then we physically validate it. And so our question here was, can we optimize structures for complex loading cases, so particularly elastic modulus and shear modulus together? And so this body-centered cube is very good in shear because it has these diagonal beams, whereas the cubic unit cell is good in tension and compression because it's aligned with the loading direction. So the question is, how do you optimally place these throughout the lattice so that you're getting, a favorable response for compression and shear, which you'd experience in the spine because you can imagine you're going to twist and bend as well, which is going to give you a shear response. And so how we do this, we code each unit cell here as a binary string. So either a 0 or 1. In this case, we kept all of the beam diameters constant, but you could change those as well. But just doing this, you get 2 to the 100, design possibilities. If it's a 10 by 10 lattice. So it's a vastly large design space, with some simple decisions. And so in order to optimize this, we used NSGA2, multi-objective optimization. You can see it, the objective functions in the bottom right. We have that elastic modulus and the shear modulus. And so what we're going to do is we're going to create a population of unit cells and scaffolds that's randomly generated. And then we're going to start creating Pareto fronts where you have the trade-offs between the two of them, where you can't improve one parameter without compromising the other. And so from those best Pareto fronts, we're going to improve that each iteration. And so that's what you see here. And we also put in a few heuristics to help it converge faster, which was seeding it with homogeneous designs. But what you'll find is through the optimization, you might expect the homogeneous designs to do the best in the extremes because they're only BC or only cubic unit cells, but actually some emergent properties from combining the two unit cells, so 4, 5, and 6, actually outperform the homogeneous design. So having them as seeding designs helps you get to a good space in the design space and then use that genetic algorithm to further improve it. And so you can see here at generation 80, we mostly converged. And you can see you can select designs that are going to be good in shear modulus or good in elastic modulus or some combination in them, depending on your system you're trying to optimize for. And so just briefly, if you look at the non-optimized designs, you can see that they, particularly this middle one that's more randomly put together than the homogeneous ones, it doesn't really have a directed mechanical response that's consistent across it in compression or shear, but whenever we optimize them, you can start seeing a more directed response here where it's more ordered and optimized for how you're distributing the stress through the system and how it's deforming under those loads. And so whenever we compared this to the physical case, this one for mostly for convenience and efficiency, we use the nylon powder printer, but you could also use the biocompatible materials and the SLA resins as well. So if you look at these optimized versus the non-optimized designs, so across the board, the best ones in tension and the best ones in shear, the optimized versions do better than the non-optimized ones. And even here in the middle, where you're compromising the values, the one that has a combination of shear and elastic modulus does both of those better than the non-optimized version. And so what this algorithm allows you to do is you can look into that implant design space and you could look at these different mechanical attributes, or we didn't show it here, but we've done it where we're multi-objective optimization with some biological attributes like tissue growth or vascular growth. And then you can get these decision and Pareto fronts so that you're able to fine tune that design response to exactly what you would want for the tissue engineering case for that particular patient. And so the conclusions today, a little bit about the future of biomechanical implants and where our lab direction is going. So there's a lot of opportunities for improving implant design. So particularly, I think with polymers, there's a lot of options as more biocompatible materials come into play, and they can mitigate problems that metal implants have where they're too strong for bone, or they're much stronger for bone, so they tend to take the load off the bone, which makes the bone less dense over the time and more apt to fracture. Future direction, so new algorithms combined with the considerations of the biomaterials and patient needs and getting that actual patient data in there could improve the state of the art in the field. Also, of course, a lot of different AI approaches could be interesting to try here as well. And with that, I'll close the talk, and I'm happy to answer any questions as well. Thank you.
Thank you so much, Dr. Egan, for this interesting presentation. Just let me check if any participant wants to make any question, please write in the question and answer box. And in the meanwhile, I have just one question, if I may. First of all, I have just a curiosity about which kind of biocompatible polymer did you test it, because maybe I missed it, or I've just seen in the first slide, one of the first slide, but I was just curious about of which type of polymer did you use. And then just another curiosity, when you presented one of the last results, of course, you said that you have found some discrepancies in the results between, of course, the experimental and the computational data. I was just wondering if you know by your experience, or if you have investigated it, if these, differences in the results, do you think that they can have an effect, in the actual final device, if this is implanted into a patient, or if it is actually used?
Yeah, thank you. So those are good questions. And the biocompatible polymer that we used was, so with stereolithography, it's hard to get a pure polymer to print. You always have to add in some kind of photo initiators as well. So the base of this was methacrylic acid with some proprietary things from the manufacturer added in as well. And so methacrylic acid has been shown to be biocompatible. They've done it in different cases where, with animal studies showing it's not toxic. It's very similar to PLA, which is used, a lot in different consumer products. But there's a lot of testing that needs to go through before you would be able to finalize that for implantation in the body. And then, yeah, for the second question, the discrepancy between the printing. So, yeah, we have a lot more data where we've done this, where you look through the microscope and then you can see all of these different like micro differences and deviances from what you intended to design to what you actually designed. And so we touched on this a little bit with the hierarchical scaffolds, where we had those scaffolds. If you tried to print the solid lattice, you designed it to be porous throughout, but the resin starts fusing in the middle, so you're not getting the design that you wanted. So if you implanted that in the patient, it would be stronger mechanically, but maybe it wouldn't allow it to, grow the tissue you needed. And so there you can make informed design decisions. So we added that big hole in the center. So where it was fusing, we made it more porous, and that was better biologically. And then I think you were asking, with the, specific the optimization compared to that nylon printing as well, the differences. So a lot of those can be scaling differences to where if you're trying to go at like the very edge of 3D printing, so like if you're trying to do a 500 micron diameter, you're going to be subject to a lot more fluctuations and differences in performance than if you're doing it at a higher diameter that's more consistent behavior. And so if you're trying to design these for the person, you'd want to design it, where you get the more consistent behaviors. And so it's not changing as much every time you manufacture it.
Thank you. Thank you so much. And okay, I just remind to all the participants that if also in the following presentation they have any questions for Dr. Egan, they can ask them in the box and we are going to share them at the end of the webinar. So I think that now we can move to the next presenter. Next presenter is Dr. Pavel Turek. Dr. Turek is an assistant professor at the Department of Manufacturing Technique and Automation, in Poland, and his research is mainly focused on, the study of the accuracy of reconstruction and manufacturing in anatomical models. And also his research is also focused on the design of orthopedic devices and implants. Today, he is joining us with a presentation entitled Use of 3D printed model with improved accuracy to plan the surgical management of a patient with isolated orbital floor fracture. So please, Dr. Egan, when you're ready, you can share your presentation.
Okay, thank you very much for this webinar to be here and present this title of my presentation, Use of 3D printing model with improved accuracy to plan the surgical management of the patient with isolated orbital floor fracture. A couple of words about me. Of course, Julia talked that I am assistant professor in Department of Manufacturing Techniques and Automation at Rzeszów University of Technology. My research interest is aimed to increase the accuracy at the stage of reconstruction, digital processing, and also at the manufacturing stage using additive manufacturing techniques. I also interested in the create surgical guide, also orthopedic devices and implant. And also I'm a lecturer at the university, so in coordinate methodology, reverse engineering, in technical and medical application, and also additive manufacturing. I present now a research team. There are the personnel which are specialized in additive manufacturing technique, also in CAD modeling, reverse engineering in medical application, also in surface roughness measurement and also geometry measurement, and also in polymer science. On the left side of this slide present people who are cooperating with me at the Rzeszów University of Technology. On the right side, we have a specialized surgeon in area of craniofacial surgery, orthopedic surgery. So we cooperate with this surgeon in special area. So in the cranial area, zygomatic bone area, orbital floor fracture, and also in mandible area, and also in area of hip bone area, and also knee bone area. So if we cooperate with the surgeon, we create for them 3D visualization of defects of anatomical structure in this area, and also create a surgical guide, for example, in the mandible area, resection guide, and also in the zygomatic bone region to create devices to prevent titanium mesh, and also devices to create final representation of implant made by using Palakos material. So also in hip bone and knee bone area, we also create final representation of the anatomical models, and also create a special path using coordinate measurement system to present in the digital stage and also in the physical stage the place where the implant would be placed. So if we talk about the orbital floor fracture, damage this area can lead a serious and permanent disorder of visual function and facial aesthetics. So if we talk about the reconstruction of this area, firstly, we create it for a visual aspect, and the second is to protect nerves and restoring sensation. So if we talk about the traditional medical methods, these methods use autogonous bone graft, for example, iliacrest or Carvarium, to create a final representation of this orbital floor geometry, but the shaping the graph directly on the patient are significantly difficult, and final shape of the graph largely depend on the operator's spatial and aesthetic imagination. So the surgeon cooperate with engineering person to create virtual surgical planning for this region. So the virtual surgical planning for this region consists, for example, 3 stages. So the first 3D imagining and virtual model. So we create 3D representation of the anatomical structure. And also the second stage using, for example, mirror technique. They are used to reconstruct the original correct shape of the damaged structure. And also the final stage is the stage we can create implant design directly on the anatomical structure, but also we can create implant modeling templates to, for example, prevent implant mesh. So if we think about the additive manufacturing of 3D model surgical guide of implant in this region, we can choose 2 paths. The first path on the left talk about the 3D printing models and guides. So this path use, for example, photopolymers materials, polycarbonate or polyamide materials or thermoplastic materials to create the final representation of the 3D model of anatomical structure or the surgical guide. The right path is consider create final implants. So in this path, we use titanium alloys or PIG material or resorbable polymers. What is the problem in the field of reconstruction, additive manufacturing of anatomical structure? The problem is in accuracy. We want to create a final representation the most accurate. So it's to represent the accurate representation, accurate model, which are very close to the anatomical, which is in the patient. So the 6th stage I present in this slide, which may cause geometry errors. So the most important, image acquisition, image reconstruction, then stage of digital processing. So we talk about the segmentation process, triangulation. Then we talk about the CAD design methods and final additive manufacturing. I present in this slide the most important parameters in these stages that affect the final accuracy of the digital model, also in this, the last path, physical model. So if we talk about create the final representation of anatomical structure in zygomatic bone region and orbital floor, of course, region, we must think about the 3 main stages. First, CT resolution. We must choose the high resolution protocol to get DICOM data. The next stage is to create the appropriate segmentation method and also design method in digital modeling stage. And the last, the manufacturing stage. So we can create 3D model. We must choose the appropriate 3D printing method to can create for us a stable dimension accuracy model. Also, if we create a final representation of anatomical structure, we also can use biocompatible materials. But if we not use it, we must choose appropriate sterilization method for the final planning surgery. So when we cooperate with the surgeon, the surgeon requests for us to decrease the cost of manufacturing models used for pre-bending titanium mesh and also increase the accuracy of the final representation of this anatomical structure. So we cooperate with them, for example, for 2 years. And we, for these 2 years, we developed the procedure that increased the accuracy both at the stage of digital processing and also manufacturing stage. Of course, we create also a fundamental representation of the model that reduce the manufacturing cost because we create not two models. Firstly, we create for the surgeon two models representing the damaged area of orbital floor and also mirrored model of undamaged site. But they want to create one model that can, on this model, determine the defect size and also pre-bending of titanium mesh. So we create one model with increased accuracy and decrease the cost of manufacturing. I said early that we cooperate with the surgeon for 2 years. We start in 2022 and we end this cooperation in 2023. We analyze 21 patients and we create the procedure which is now patented. The procedure named tomography, acoustics, reconstruction, modeling, and manufacturing. So this procedure consists different stages. So the first stage, of course, acquisition stage, then image processing on a datum data. So we talk about the interpolation process, segmentation, and also reconstruction. Then we start a stage which involve a CAD modeling process, then additive manufacturing. We also have a stage which in this stage we analyze surface roughness parameters and geometry accuracy before and after sterilization process. This analyze I don't present in this presentation because the article is now under review, representing a result on this stage. So I don't present the final result of this stage, but I present the final representation of the planning procedure on this created final model using this procedure. So we start with the image acquisition and processing stage. We use a high resolution measurement protocol. The CT layer for this protocol is 0.7 millimeters. But if we talk about the orbital bone, it's very thin. The bone is very thin, so the thickness is from 0.74 millimeters to 1.5 millimeters. So there are places that this thickness is very close to this value of the layer thickness. So it's a problem when we create the final representation of this area, because in the acquisition process we create an isotropic structure of voxel. So we acquisition stage creates stair-step artifact and also volume averaging artifact. So it's a problem with the final representation of whole bone of this area. So we try to firstly, of course, choose the most accurate measurement protocol, but then after get the data, we create we choose the interpolation process on a datum data to minimize this effect. So we now it is a isotropic structure and also change the voxel size to 0.4 the pixel size, and layer thickness 0.4, not 0.7. So we have more accurate representation of this area. Then we choose the segmentation process. When we start to cooperate with surgeon, we use traditional thresholding method. Also, we use a local thresholding method to increase the accuracy of the representation. But when we choose interpolation process, we think that we may choose more accurate segmentation process of this area. So we choose not thresholding method, but random forest machine learning method. These methods classify a group of based on classification using a group of decision trees, and this process binarize a 3D image. So we have the area representing the anatomical structure of bone and the all regions that we are not interested. This segmentation may improve the visualization of this area. So we don't have a lot of problem when we talk about the final representation of this structure when we use random forest machine learning method. Then we choose the reconstruction process, using Marching Cube algorithm. And in this slide, I present the first choose of reconstruction. So we don't use interpolation process, we choose thresholding method, and the final representation look like this. When we choose interpolation process and a random forest segmentation method, we have more area that are reconstruct in the mid phase of the patient. If we have choose the Marching Cube algorithm, there create programming errors. But there is no problem because we choose the automated function in a CAD system that decrease the influence of these errors. But also, when we think about the final saving 3D representation to the STL file, we choose horizontal deviation less than 0.01 and also angular tolerance less than 10 degrees to not copy these errors at the stage of additive manufacturing process. In CAD modeling process, we have different stages. So first we start like was in the start of cooperating with surgeons. So we create two models. One model is representing the defect area, then the second represent the mirrored model. Then we choose a best fit algorithm to fit two models together. And then we choose the CAD modeling process. First, we create curves representing the defect area. This defect area we cut on the model that are not defected, not damaged. So we choose first we create curves that create the closed area. Where we have closed area, we extruded this area, and then using bonding operation, we create cut on the final model. So we create one model representing undamaged side, but there, on this model we have cut area of damage model. In Rzeszów University, we have a different additive manufacturing technique. We talk about the anatomical models. We choose mostly FDM, FFF process, PolyJet, DLP, and SLS process. Surgeons talk to us that they want to have a cheaper version of 3D model, so we choose FFF Prusa 3D printer. In this stage, we create the final G-code representing different area. So we choose a variable layer height to create one region that are not interested in the final 3D bending of titanium mesh. So it is this area and this area. The layer thickness was in this area 0.3, and then most important for us, this area is marked by green color. We in this area choose option the highest resolution of layer thickness 0.07 millimeters. So the final representation of the 3D printed model look like this. So we have one model that representing undamaged part, and on this model there are cut area of damage. We have also have a two area. This area is manufactured using 0.07 millimeters. So we decrease the manufacturing model because we don't use for all area one uniform layer thickness 0.07. And then we have a 3D model. We choose the appropriate sterilization method. So when we cooperate with the surgeon, we have analyzes. What I said earlier, I don't present in this presentation because article is under review. But we, after this analysis, we choose the appropriate low temperature sterilization method, hydrogen peroxide plasma. The advantages of this method, this method not give so much deformation of the 3D printed model. This sterilization process is safety, and the short sterilization cycle is also advantage of this method. The surgeon now use this one model to create the final shape of the titanium mesh. And also we cooperate with the surgeon to create more extensive analysis, for example, to create surgical guide in this area. But now we are cooperate also in mandible area. So so we cooperate with different area now. And the last slide, conclusion. We use high resolution CT protocol and digital processing of DICOM to significantly increase the geometric reconstruction process. Also implemented additive manufacturing method FFF to reduce the production cost. We also use variable layer thickness to increase the time of the 3D printing. And also we choose the hydrogen peroxide plasma sterilization to sterilize this model before surgical planning. Thank you for your attention.
Thank you, Dr. Turek. We have one question for you in the box, so I'm going to read it. They are asking if your patented procedure is already used in practice.
Yes, now is the surgeon in Rzeszów hospitals use this procedure. So we first 2 years spent to create this procedure. Now is implemented and used in surgical procedure in this hospital.
Okay, thank you. And from my side, just curiosity about the reconstruction, of the 3D geometry from the CT scan. You have compared the use of the threshold method and use of an interpolation method. And of course, in the picture, we have seen that the geometry that you obtain as a result of the interpolation method, of course, is smoother. And also you have that some areas are filled. But I was just wondering if you have an idea, how much, in the interpolation method, how much you can be sure about the reconstructed area by the software?
Okay. So now we analyze, for example, we create this is the start of our analysis. We create a model that we choose for analyzing by CT scanner. We use this protocol when we use after reconstructing anatomical model. And then we analyze on this model, we have nominal model. So we now, after the reconstruction, we analyze different options that we can create, how much the interpolation process is more representing the final anatomical structure. So we analyze this option, but now we choose this model because we don't have any other option to create the final representation for this hospital. So the protocol is 0.7. So now we try to cooperate with that, but we analyze more this procedure by creating nominal model, then manufacture them and then analyze the different interpolation process, which can create the final representation of the anatomy geometry which are analyzed.
Thank you so much.
Thank you.
So is there any other question from the audience? Okay, so thank you again, Dr. Turek, and we can move to the next presenter. Our next speaker is Dr. Andreas Kantaros. Dr. Kantaros is a researcher at the Department of Industrial Design and Production Engineering at the University of West Attica. And his research is main focus on 3D imaging, additive manufacturing, and the study of advanced materials for applications mainly in healthcare and also smart cities. And his work dealt also with the 3D scanning, and his research is also focused on biomimetic and 4D printing of medical devices. Today, he's going to provide us a presentation entitled From 3D to 4D, Smart and Biomimetic Design Strategies for Implantable Medical Devices. So please, Dr. Kantaros, when you want, you can share your screen. Yes.
Thank you for the introduction. My presentation has the title From 3D to 4D, Smart and Biomimetic Design Strategies for Implantable Medical Devices. Let's say that it is more a conceptual perspective presentation showing or trying to show where we were, where we are now, and where we wanna go, where we wanna reach. So, as a first introduction, we all know that additive manufacturing has revolutionized medical device design through precision and personalization. Additive manufacturing has the ability to fabricate custom devices, custom objects, and of course, this is perfect for manufacturing a custom implant. So, transitioning from the well-known static 3D printing to dynamic 4D printing introduces the time-responsive functionality and the factor of change due to external stimuli. So, in this context, smart materials come to assist us. Smart materials enable implants to adapt to physiological conditions in the post-implantation stage. So we have a technique that is not static, it is a dynamic technique based on the materials that are responsive and can change, can shift their design due to external stimuli, and smart materials assist us more in this direction. So, of course, we can manufacture whatever we have designed. So, biomimetic design draws inspiration from nature, for improved compatibility and performance. So, the goal is to develop adaptive, safe, and sustainable implantable medical devices through what we call conscious design. Biomimicry, in the context of biomimetic design, involves drawing inspiration from natural structures, processes, and systems to solve design challenge. It is something of paramount importance. Biological tissues such as bone, cartilage, and skin provide the perfect blueprints, let's say, for strength, flexibility, and self-healing. And in this direction, hierarchical and gradient architectures found actually in the nature have the ability to let us improve the mechanical performance and tissue integration of the implants that we design and manufacture. In the same context of biomimetic design principles, biomimetic designs have the ability to enhance implant biocompatibility by exactly mimicking the natural morphology and functional behavior. Thus, combining biomimicry with additive manufacture seems to be the perfect combination because it enables precise replication of complex biological geometry. It's a field that actually inspires us in the design part. So, we've said about the process, we've said about the abilities. To our aid come the smart materials. Smart materials in 4D printing is exactly the materials that we want and enable us actually to 4D print something. So from smart materials, we choose the subcategory of stimuli responsive materials, such as the so-called SMPs, the shape memory polymers, and hydrogels, for example, which enable implants to adapt dynamically to physiological conditions. Ideally, if we have an implant that, of course, we have designed properly and according to the topology to the place of defect, if we have impacts that have the ability to adapt to this special defect topology, theoretically we have something that is close to perfect. Functional responsiveness to temperature, moisture, or pH allows the controlled shape transformation of such materials and allows for improved integration with surrounding tissues, which, as we all know, is of paramount importance for implants. So, combining smart materials with additive manufacturing enables the creation of adaptive, patient-specific implants that have enhanced performance and minimal invasiveness. We will see in the continuation of this presentation what we mean by minimal invasiveness, which is of truly great importance in this sector of implants. So, as we said, a prominent category of smart materials are the so-called SMPs, the shape memory polymers. Shape memory polymers can recover their original shape after deformation when exposed to a specific stimuli such as heat, light, or moisture. Theoretically, they are the perfect materials to perform the so-called 4D printing. As we can see in the picture, this is one of the first documented cases of such a case where the SMPs were used and with the application of external stimuli, in this case heat, and with a tailored design, which is thicker above and thinner in the gripper section, the grippers tend to contract at a specific point when heat is applied. So, in this case, they have the ability to actually grip this screw. So, it is something that was unimaginable some years ago, and now there is a continuous a continuous progress, excuse me, in this field. So, in implantable devices, in our case in the biomedical sector, SMPs enable minimal invasive deployment, expanding or reshaping once inside the body to fit anatomical structure. This is something obviously highly desirable because something can be inserted in a more contracted way in its minimal, let's say, dimensions, and once implanted, it can actually expand and gain the exact size that we want. Obviously, as we will discuss in the continuation of this presentation, this is actually a challenge because we have to actually map as perfectly as we can the defect site, the implant site, the site of implantation, and map its exact conditions as temperature, moisture, let's say, so we can tailor our implant to do what we want, to contract, to expand in any direction that we want, that it is something that it is design and material and stimuli, as I've said, dependent. So additive manufacturing allows precise control, obviously over geometry and transition temperature, optimizing the performance of a shape memory polymer for personalized biomedical application. So this is more or less the concept in SMPs. In hydrogels, which are water-swollen polymer networks capable of large reversible volume changes in response to stimuli such as pH, temperature, or ionic strength in this case. So their tissue-like softness and increased biocompatibility, this is a high advantage of such materials, make them ideal for implants, drug delivery systems, and tissue engineering scaffolds. So, when combined with additive manufacturing, when used as the raw materials in additive manufacturing, hydrogels can enable precise spatial control of porosity and responsiveness, allowing the creation of dynamic biofunctional implants that interact with their environment. So let's move to the concept or the term that we like, the so-called conscious design for biocompatibility and regulation. Conscious design integrates material selection, structural design, and functional performance with, of course, things that we want, patient safety and ethical responsibility from the earliest stage of development. That this is something that we want to have in mind, to bear in mind from the initial stages of development, from the design stages. So, biocompatibility is a crucial factor, as we all know. It requires assessing factors like cytotoxicity, immune response, potential degradation products when implanted, and long-term stability according to standards such as ISO 10993. The geometry and surface characteristics of additively manufacturing implants, obviously, as we've seen in the presentations like Egan's and like Professor Egan and Professor Turek, affect cell adhesion, osseointegration, and tissue response. Thus, it is something that demands very precise design control. So in this context as well, regulatory compliance involves adherence to frameworks such as the FDA's and the EU's frameworks, emphasizing factors like traceability, where these implants came from, where the raw materials that the implants were manufactured from came actually from, reproducibility. Is it something, have we perfected so much our techniques that we can, let's say, reproduce the implants we want with in a numerous way and in a precise way, and risk management throughout the design process. So, in this way, as we say in general, in more general terms for 3D printing, we say design for manufacturing. Here we say design for regulation. That means that we must incorporate testing, validation, and documentation strategies early, thus reducing delays in certification and clinical translation. So it is something that we actually can design and 3D or let's say 4D print, but we must have in mind such regulations prior to manufacturing in order to avoid costly mistakes and delays. So conscious design also promotes another factor that is obviously something that we want, sustainability and ethical innovation, ensuring that novel materials and methods align as much as we can with both medical efficacy and societal responsibility. Many things to have in mind, but it is the only way because this sector has its own specialities that we must have in mind. So, some case studies that were that I want to share with you today in 4D printing. A perfect example for 4D for a 4D printed implant is the self-expanding tracheal stents that have the ability to adapt to airway dimension. Uh, Obviously, as we can understand, stents are not only tracheal stents, but stents in general are the perfect item for the printing because we want it to be, as we said, minimally invasive. The practitioner, the doctor has wants it to be as minimally invasive so that he or she can implant it in the safest way possible, or for example, from veins that can be clogged. So stents must be as minimal as possible. So in this way that things can be clogged as well. For the printed tracheal stents made from the first category of smart materials that I shared with you, the so-called shape memory polymers, can self-expand at body temperature after insertion. So this sounds and is ideal. In this way, we can provide a minimally invasive placement throughout the procedure, reducing trauma and improving patient comfort. The adaptive temperature, the adaptive, structure itself maintains airway patency while accommodating dynamic changes in tracheal geometry during breathing. Another case, apart from stents and tracheal stents more specifically, are the so-called smart wood dressings. Something that we've all used from, an item that we've all used since our childhood. However, these are smart wound dressings that have the ability to release drugs based on the exact wound's pH. So, hydrogels, the second smart material category that I've introduced in the prior slides, integrated with pH responsive materials, release therapeutic agents only in infected or inflamed environments. So, a selective drug release, let's say. So in this way, we can enable controlled, on-demand drug delivery for faster healing and reduced side effects. We can, in this way, deliver, release, let's say, what we want, where we want, and in a faster way. So in this way, additive manufacturing allows customized thickness and porosity, tailoring the dressing to the exact wound type and exudate level. So this is also something of this is also a case that has very high importance, and this kind of technology, 4D printing, additive manufacturing in the greater sense, let's say, along with the specific smart materials, can immensely contribute. Of course, one prominent sector, the customizable bone scaffolds, the 4D printed scaffolds with biomimetic gradients and shape memory features conform precisely to defect sites. So it is something that we design, we can manufacture, but it is something that can adapt to defect sites. It can support osteoconductions and vascularization through optimized pore architecture, something that we've seen also in the previous presentations. And also, something very important here, it can employ bioresorbable polymers or composites that degrade safely. In this way, synchronizing the scaffold resorption with tissue regrowth. As it is well known for a number of years now, a crucial design and manufacturing characteristic of the scaffolds is that we want them to be bioresorbable. We want them to decompose after a certain period of time so that they actually give space for what has to be regenerated. This can be skin, this can be used, this can be bone in this bone tissue in this case. So in this way, with these smart materials, we can more safely, more easily predict, or we can tailor, let's say, the bioresorbability of these custom scaffolds for whatever application that we want. So in this way, we have greater control of what we want to fabricate and how it will progress once implanted in the body, in the patient's body. Are there challenges in all this thematic? Of course, there are challenges. We have limited long-term biocompatibility data for these materials. They are novel materials, they are new materials for smart and stimuli-responsive materials in vivo. Also, another challenge is the variability in additive manufacturing parameters that affects reproducibility and mechanical reliability of implants. As we all know, the mechanical properties or the mechanical behavior, let's say, of an implant is highly dependent on its design. So, and also in its material. So, in this way, we are not yet in a stage to surely claim that we have achieved the perfect reproducibility and mechanical reliability of the implants that we fabricate, even if we do that in a small batch production. Also, sterilization in post-processing can alter material properties or trigger premature activation in 4D printed devices. Post-processing stages, which are inevitable in some cases, like for example in SLA 3D printers, can actually trigger the activation of the 4 printed materials. So this is something that it is not desirable. Also, sterilization is something of great importance and also biocompatibility, if I might say, because in 3D printing we have witnessed the case where a raw material is actually classified as biocompatible, but post 3D printing, after its manufacturing, after its fabrication, let's better say, with 3D printing, it is not at that stage biocompatible because the process itself is not biocompatible categorized. So there are still challenges that need to be addressed. Also,
Sorry,
another.
Dr. Kantaros, you have only 1 other minute, please.
Okay, I'm sorry. Yes, thank you, Dr. Pascoletti. So, also there are unpredictable behavior in biological and bioenvironments. As I said, the place where we want to implant when we want to actually put the implant on. and lack of standardized testing protocols for evaluating adaptive or time-dependent performance of 4D printed devices. So there are also other regulatory and ethical considerations. Existing medical device regulations are not yet fully adapted to dynamic programmable implants. We're not there yet. Traceability, a factor that I've also mentioned in our previous slides, and validation challenges in multi-material patient-specific manufacturing also is not yet in a mature state, and ethical issues regarding safety, patient consent, and long-term monitoring of self-adaptive devices are also present. So, Dr. Pascoletti, if I have 1 or 2 minutes, let's say, to discuss the future trends in these implants. Of course, sensors and electronics can be integrated in these implants. AI, of course, it's something that can assist in the design, and digital twins of the site of implantation is something that is also being discussed. And also the development of multi-material bioprinting expands functional complexity, combining structural, conductive, and bioactive components in just one process. So, if I may move on, the responsible development of next generation adaptive implants has to consider the ethical innovation, interdisciplinary collaboration. The factors of sustainability and accountability are of paramount importance in this stage. And if I may conclude, moving from 3D to 4D allows us to move towards adaptive and time-responsive implants. This is allowed by the use of smart and biomimetic design combined with smart raw materials. The next generation implants will merge material science, AI, and biofabrication. This was and will be an interdisciplinary field. Collaboration and responsibility will drive innovation towards this direction, and the journey from concept to clinic will depend on our ability to design adaptively, ethically, and with a vision for human-centered progress. So, thank you for your attention and your time.
Thank you so much, Dr. Kantaros. Okay, we are a little bit out of time, so I have a very quick question. I was just wondering, based on your experience and what you have showed to us today, if do you think that there is one of the, devices or technology that you showed us that up to date, today is more ready for the market? So do you think that there is something that is about the using of 4D printing and shape memory polymers that is very close to be ready for the market?
Yes, I believe that the SMPs combined with bioprinting, with bioprinters, is something that is actually close to the market. Bioprinters are advertised as ready to use products that are not only addressed towards research institutes, but also to the private sectors as end-use products. And also, as the regulatory framework has evolved, the big question is not about the devices or the materials that more or less are ready to be commercialized, but how this technology and these aspects can be actually adopted by the end users of private sectors and can be viewed as a final end product. I believe that we are not there yet, but we are not very far from that point, to be honest.
Okay, thank you. Thank you so much again for your presentation. And we can now move to our last speaker. Our last speaker is Professor Elisabetta Zanetti. Professor Zanetti is an associate professor in bioengineering at the Department of Engineering at the University of Perugia. And her research is mainly focused on biomechanics and biomaterials, and she is an expert in the creation and development of numerical models and also experimental stress analysis for implantable devices. Today, she is going to give us a presentation about the regulatory pathway for custom-made medical devices. Please, Professor Zanetti, when you're ready, you can share your screen.
So, good evening to ladies and gentlemen, and thank you for my introduction to Dr. Pascoletti. Sorry, I've missed it. My presentation has disappeared. Where is it? Okay, here we are. So my lecture will be focused mainly on regulatory aspects concerning custom-made medical devices. And the main objective of this lecture is to try to underline who is responsible for these devices. Is it the doctor or the prescriptioner? Is it the designer or the manufacturer? And also, who can produce these devices? Is it enough to have a 3D printer to produce these devices, or is there some more requisites? And finally, when recurring to custom-made device is allowed? In order to answer these questions, I will refer mainly to the Medical Device Regulation of EU, that is 745, and to ISO standard 13485 concerning quality management system for medical devices. Finally, I will refer to IMDRF, that is a voluntary group of medical device regulators aiming to accelerate international medical device regulatory harmonization and convergence. The first step, I would like to underline what we mean with the custom-made devices. In fact, there is a very broad category, that is the one of personalized medical devices, which actually include three categories: patient-matched devices, patient-adapted devices, and custom-made devices. First, if we wanted to understand what are patient-matched devices, these are devices which are designed for a particular individual, but they have some specificity because no written request of an authorized healthcare professional is required, and these devices are not strictly required to meet an individual's need. All these devices are under the responsibility of the manufacturer. Here we can see some examples of patient-matched devices, such as a cranial implant, surgical guides, or orthodontic aligners. The second class is the one of adaptable device. This is completely different because they are not designed for a particular individual. They are mass-produced, and they can be adapted in a second stage to the patient. Again, we are under the complete responsibility of manufacturer. Finally, we come to the class of devices that is the focus of this lecture, that are custom-made devices. In order to be qualified as a custom-made devices, at least three conditions have to be met. The first one is that they are designed for a specific patient. Second, there should be a written request of an authorized professional. And finally, third requisite, the healthcare professional should testify that these devices are strictly necessary to meet an individual need. If all these conditions are met, we are in the field of custom-made device, and the design of this device is the responsibility of the healthcare professional. It could seem singular that the custom-made devices have partially a different regulation from standard device. The reason for this comes from history itself, because at the very beginning, these devices, custom-made devices, were rather exceptional, and actually they more oftenly included low-risk products. So the need of regulation was not felt so heavy. But as we all know, things now have changed, mainly thanks to additive and subtractive technologies, which have made this custom-made device available to a much broader audience. In view of this, there was the need to cover patients from a regulatory point of view. But at the same time, the second condition was regulation had not to compromise the availability and the development of these new opportunities. So here we can see some images explaining that failures did actually occur, and so regulation was needed both for design, for processing, for instruction, for use. If we look at the workflow for medical devices certification, we can see that the difference between custom-made device and the standard one mainly takes place at the step 6 of this procedure, so where we find product verification and validation. And the reason is that the custom-made devices are exempt from clinical evaluation. And it could not be different, because this would not be a viable option for devices which are actually made one by one. Nonetheless, some main requirements, of course, have been fixed, and they concern, first of all, the manufacturer. You see that the manufacturer should be registered, and he must ensure that the traceability of devices. And it is important, it is recommended that the custom-made medical device and their manufacturers are registered or notified to the regulatory authority. Secondly, the manufacturer producing a custom-made device should provide both the technical document describing the device itself and the so-called statement. We will go deeper on these documents, explaining what they are. One more requisite is that for Class 3 devices, where a quality management system must be set up, and we will try to understand what is this. So here you can see the full path leading to compliance for custom-made medical devices. On step A, we have the eligibility. Is this a custom-made device? We have already said when and how we can see if it is actually a custom-made device. The second step is designating a person responsible for regulatory compliance. There are specified in the directive the qualification of this person, who should hold a university degree, or alternatively should have a 4-year professional experience. This is the person responsible for regulatory compliance. Then we come to point D. We leave point C for later because it is limited to Class 3 devices. So moving to point D, we find that the manufacturer should provide a statement and a technical file. What is this statement? Statement can be equated with a sort of declaration of conformity, as it provides overall assurance that the general safety and performance requirements have been met by the custom-made device. More in detail, this document should include data allowing the identification of the device and a section that indicates clearly that the device is intended for the exclusive use of a particular individual. Then there should be the name of the authorized healthcare professional who made the description of the device, the main characteristics of this device, the compliance, as we say, with general safety and performance requirements. In case of class 3, we have one more request, that is the verification of the documentation from a notified body. This statement should be kept for 10 years or even for 15 years in case of implantable devices. All the documentation should be available to competent authorities on request. To go a bit deeper, here we can see a statement example. On the left, we have a sort of format to be followed, and on the right, we have the filled modules. So we can see quite clearly that here the manufacturer is just an example, a fantasy example, this one. Here we can see details about the manufacturer, details about the device, and the clear explanation of the intended purpose of this device. Secondly, there are patient information. In order to guarantee his privacy, usually a code like this is used rather than providing name and surname. All details concerning the healthcare professional who prescribed this device with the prescription details. For example, this example refers to a mandibular plate, and here in the prescription we find requirements for a custom contoured titanium mandibular plate with thread station holes compatible with 2 mm locking screws. The plate geometry was validated by the surgeon prior to manufacturing. The next step is the checklist concerning the general safety and performance requirements. In this case, the relevant requirements were number 1, biocompatibility, number 10, mechanical properties, and number 23, which requires an accurate label and the provision of instruction for use. In case of class 3 device, we can find one more information, that is which notified body has reviewed the documentation and when it did. This is not all, because in addition to the statement, there is the so-called technical file. We have seen some example in the course of this seminar. I have seen that my colleagues provided a lot of information about that, so just a few points. In the technical documentation, there is the description of the device, its intended purpose, all design and specifications, and especially details about the expected performance. The manufacturer should provide a risk management file, all information concerning biologic evaluation and biocompatibility. There should be all information, details about which verification and validation have been performed and how was the device manufactured, and above all, a main word, a key word is traceability. It is necessary to be able to trace the full history of the device. And finally, we have the post-market surveillance plan. So again, we see on the left the list of information to provide, and on the right an example of information provided in the case of the custom 3D printed titanium mandibular implant. That is a class 3 device because it is an implantable device. And so you see there is a device description, all information, and specifically the label that should include the statement custom-made device, and should include detailed instruction for use and a code that identifies clearly the device. Then there are details about manufacture. So how was the CAD model obtained? How were eventual numerical or stress analysis performed? How was built the device? with which kind of 3D printer, which parameters, and all details concerning post-processing, could be high pressure or machining or anodization, and which quality check have been performed. The next step is the verification of general safety and performance requirements. We have already seen this in the statement. Then the manufacturer should provide the risk management file. And in the next slide, I have considered from literature an example of an anterior fixator for spine deformity in order to explain better what is a risk analysis file. Here you see that there are some main issues, such as anatomical positioning of the implant. Then there should be written clearly the requirements must not interfere with anatomical structures in the cervical and thoracic spine. The variables playing a role in satisfying the requirements are explicitly acknowledged: size of the implant, thickness of the implant, and the way that they are optimized is given in the justification. Cadaveric trial surgery before implantation, experience of the surgery team, literature. We can see this also for other voices. For example, if we want to consider material properties, here the requirement is must not cause adverse tissue reaction. The variables playing a role are the material itself and the post-processing process. The justification in this case can be fully found in literature. So this is the risk analysis that should be provided. And in the next step is the verification and the validation. If we refer to orthopedic or orthodontic like display devices, the experimental validation very often includes some sort of mechanical tests. Here we have the case of a 3D printed humerus, and so there is a loading test to check the strength of this device. Again, we must report detail of the whole procedure, so which is the testing machine, and how many cycles, which load, which boundary conditions, which sensors have been used, and so on. In addition to experimental validation, also numerical validation can be performed. Usually, this is performed because the mechanical tests are in a very confined loading case. Numerical tests can include a large variety of possible boundary conditions of loads which are implemented. Again, it's required to report full details, that is the code that has been used, which is the mesh size, the number of elements, the type of element, material properties, boundary conditions, and so on. One more step is the clinical evaluation. This is usually performed based on predicate devices, that is analogous devices which are not custom made. And in point 8, we find the post-market surveillance plan, and we will give details about that. Finally, point 9 concerns the notified body verification, who is the notified body and when the verification was performed, and the list of annexes. We still have to develop a bit more what is the post-market surveillance. And setting up a plan for post-market surveillance means setting up procedures to collect and assess device performance and vigilance reporting of serious accidents or field safety corrective actions. So, I think the main points are clear: the statement, the traceability, the NOI-CE mark, NOI-EU declaration, and the traceability we said, and the device classification. I would spend some more words concerning the quality management system, because as a medical device, This concept was established. Now we move from products to producer, to system to producer. The concept was established having considered that a new way of manufacturing medical products was being established. Consider, for example, 3D printing facilities in hospitals or in point of care. So is the way when these points of manufacturing should be somehow regulated, and the main objective was to provide a regulated way for hospitals and healthcare providers to manufacture devices on site. Main difference between device and medical production system is that on the device we speak of an individual device. Here we speak of a system to produce multiple devices. So it's not surprising that custom-made devices do not need to be CE marked, while medical device production system need to be CE marked. The notified body, in this case, must verify the production system for class 2A or higher, so even less than class 3. The instrument to guarantee that the device production system is able to perform reliably and consistently is setting up a quality management system. So, according to the standard, an organization needs to demonstrate its ability to provide medical devices that consistently meet customer needs. The production of a custom-made device, as we have seen in this seminar, is a very complex process. A quality management system is needed. Here you can see that there are really many steps because you have to obtain input data with known resolution. You have to process this data with controlled software and processing. You have to perform numerical validation to set up the process, to check the results, to validate mechanically the output. So many steps that in order to check all of this, you need a quality management system. Setting up this system is the only way to guarantee the traceability, the process control, the risk management, and so that we can avoid these failures that were mainly due to the design that was not so careful, or to some problem in the process, or some insufficient instruction for use. So, as a final message, we could say that current regulations were inspired by a simple principle. On one side, we wanted to protect the patient, but at the same time, we do not want to miss the benefits of all these new technologies. These new regulations seems to be very effective because we have the quality management system, we have a full traceability, and designers are forced to take into account current knowledge and avail themselves of well-known methodologies, which can be numerical and experimental. But it is still the prescriptioner who is responsible for ensuring that the device is appropriately customized for the patient need. This last point can be critical, especially in view of the complexities of the technological process. And so it's quite likely that the prescriptioner is not fully aware of all specifications which need to be fulfilled. Consider, for example, an engineer who is working with a medical doctor on a custom-made prosthesis. The technician can provide his view and his advice, but the prescriptioner, according to this regulation, is still expected to have the last word. And with this, I conclude. Thank you very much for your attention.
Thank you, Professor Zanetti, for your presentation. I mean, while we are waiting, if someone from the audience has any question, I want just to ask you a very brief question. I mean, you have spoke about the use of numerical models and numerical methods like finite element models for the validation. But I was wondering if, is the use of these numerical tools admitted by the regulation? I mean, we can find currently any detail about the use of these numerical methods in the regulations?
Okay, thank you very much for the question. So numerical methods are indeed admitted, but there is one main difference between US regulation and EU regulation, because referring to FDA has already specifically addressed this issue, since it has provided a specific document where there are all details to be followed for a validated numerical analysis. So how you choose the number of elements, how you choose the boundary condition, how you validate the model. In EU, this issue can be considered to be broadly covered by ISO 13485, but it has not been specifically addressed by now.
Okay, thank you. Thank you so much. Okay, so I think that we don't have any other question from the audience, so I think that we can proceed with the conclusion of this webinar. And so from my side, I would like to thank the speakers for all the presentations that they have provided, because I think that we have seen different aspects about the topic of this webinar, and each of them was very interesting. So thank you so much. And thank you to all the participants that, have joined us at this webinar. So from my side is everything, and I leave the speech to Xenia.
Thank you very much for, I'm sorry, I hear myself. Okay. Thank you very much for this webinar, for your time, for participation, of course, for our participants, and of course, great thanks from our journal designs and from the company MDPI to speakers and to our chair for your time, for your sharing your ideas, your new research results. It was really interesting, and I'm sure that if some of participants still will have questions, they always can contact us and we will forward these questions to our speakers. And from my side, I would like just to remind our participants that this webinar is connected to the special issue that is guest edited by Dr. Giulia Pascaletti and Dr. Ariana Rossi. The special issues title is Advanced Design Methodologies for Additive Manufacturing in Patient-Specific Medical Solutions. And if you are interested in submitting your research to this special issue, you can find all details about this special issue in the link that you have in the chat. Also, if you are interested in getting the certificates of attendance, please kindly access your dashboard on SciForumNet, and it can be found under My Certificates. You can find the link also in the chat. And of course, we would like to ask you to share your feedback with us, because it's very important for us to know what was good, what can be improved. And we would very much appreciate it if you could spend a couple of minutes filling out our satisfaction survey. And the link also you can find in the chat. And now I would like to once again to thank all of our participants, speakers, and chair. And I wish you, to some of you, a good evening, to some of you a good productive day. And I hope that we will have possibility to meet each other once again in our other events.